Hi, afternoon, everyone. I hope you can all hear me okay. We're going to try and do a quick session talking about echo and ultrasound in trauma patients. I'm going to use Bob to try and demonstrate all the pathologies that I think are relevant. First of all, can everyone just hear me? Just give me a wave if you can hear me okay. Sweet, excellent. If you can't, because I'm trying to record on one computer and do it on another, so if the AV fails, please just let me know. This is a question that I guess gets asked a fair amount, but I guess more importantly, I think this has got real play clinically, obviously, because I think ultrasound in a trauma scenario can be extremely useful, but there are a few overarching principles that I think are important to adhere to, and one of the first being the fact that recognizing that it's useful, but you can't get in the way. This is an adjunct to everything. If you're going to be doing fast scans, looking for pneumothoraces, we're going to be looking at more complex things in the hearts, all of which we'll go through. That shouldn't get in the way of active resuscitation, getting in lines and things like that. But very much I've found that this can be useful in my practice. When I used to work in a trauma center, I'm not working in one now. So if anyone is spending more time with trauma patients and they feel like they have things to add, I would certainly appreciate some input, because I certainly don't feel like an expert in these, which is why I need Bob, because I don't have a whole bank of beautiful pictures to show you. I'm coming at this as a avid enthusiast rather than expert, so please interrupt me, okay? What I was thinking is, first of all, let's just go through ideas of what we're going to be trying to look at here. So in trauma, I think ultrasound can be useful because it's non-invasive, it can be done fast, we can get immediate feedback of results, we don't have to transport the patient, and it can be done in adjunct to other things. The dangers of it, as I just said, is that focus, and certainly I've seen this and probably been a part of this when I was first learning ultrasound, is that you shouldn't get focused entirely on the echo or the fast scan. You know, this is about the patient, it's not about the ultrasound image, and you've got to integrate your findings into the care of the patient. So particularly fast scans, if someone's horrifically unstable, not responding to treatment, you've got a positive fast scan, go straight to theatre. But don't go straight to theatre just because you've got a positive fast scan at the behest of adequate resuscitation, for example. Fast scan is going to help you pick up free fluid in the abdomen, as we'll see. It can pick up really small amounts of fluid and help direct you, but you're going to miss a lot of things. For example, you cannot diagnose bowel injuries. You probably can't diagnose at the level that I'm certainly at, and maybe we're at, of looking at solid organ injuries like kidneys, spleens, livers. We're not able to exclude those. So fast is not good at excluding, but it's maybe quite good at including things so that we can go for further investigations. We should understand that I think pneumothoraces and lung ultrasounds, echo can be really useful for that, and ultrasound can be useful for that, but it's not perfect. And anyone who does this in real life will agree that it's not 100%, and you've got to use your gestalt and use other imaging methods when you have to. And just be careful about causing pneumothoraces when you've got a right lung, a right endobronchial intubation or something like that. You know, it's easy to maybe make mistakes with lung ultrasound sometimes. But then also the utility of using advanced echo things down the track, and we'll talk a little bit about echo and trauma, and I'll try and use all the pathologies and you guys helping me to figure out where we're going with this. Okay. Any other thoughts just before we crack on from people who work in trauma centres? I don't know if anyone wants to say anything else. Okay, there are no comments, then you're stuck with me, and we're going to go through the pathology. Okay, so first of all, talk about the fast scan, and I'm going to use obviously we don't normally use an echo probe for this. We're going to use an abdominal probe, but it takes quite a long time to load up the pathology. Load up the probes when we do it. So the fast scans, if I can ask you to imagine this is an abdominal probe and then we'd switch around when we were doing echo, that would be appreciated. But if you imagine this is an abdo probe, I think the first thing that I'd do is I'd change this to the abdominal presets if I could, because at the moment you can see that the image that's related to the little button that's on the top, that little button that's at the top of the probe, is normally facing on the right side of the image with an echo image. When you're doing abdominal, it's on the other side. So I'll just move it around there. And then we're going to be looking in the sort of that right sort of mid-axillary line, trying to find a way where you've got the liver as the acoustic window. I've got that marker pointing towards the patient's head, and I'm going to be fanning through that structure. So someone give us a shout out whether you think this is normal or abnormal. And so the important thing with the fast scan is to scan through the whole image. You can see if I maybe take off some of the visibility of this stuff and just have the image there. It's the importance of fanning through that whole structure, of looking in here. Can someone remind me what this is called? Morrison's pouch, beautiful. So here in Morrison's pouch, so you've got the liver up at the top, and then you've got the right kidney underneath. So if I put those back in, you'll get the idea. And so it's really important to be able to fan through that whole of that structure, looking for quite a small amount of fluid. And that's that sort of, that echo-free space that's fitting in there is fluid, obviously sitting where there shouldn't be fluid. And that is Morrison's pouch with probably around about 100, 200 mils of fluid in there. Okay, so that would be a positive fast scan. If you get in one spot, don't forget to go and have a look at the other side. So the other side, we're going to use the spleen. I can't remember if I've got a spleen in here, actually. Spleen. Okay, so the same thing happens on the other side. I have my marker pointing towards the, trying to get in between the ribs, trying to get in the rib spaces, trying to find my spleen. It's sitting just in here. There's meant to be the diaphragm, lung up at the top. I'm looking for that. Going to be fanning through that whole structure, going from one side to the other. If you get something that's missing in there, just try and slide up a little bit just to try and get into your rib space. We're trying to get through that entire three-dimensional structure. So yeah, two-dimensional imaging tool, three-dimensional structure, try and get in there and scan all the way through, okay? And this is what a normal one might look like. Sorry if I can try and do two things at once. Try and fan through it. There is no echo-free space, so that is clear. Okay, and then the last one would be coming down into the veso or retriculovesical or whatever you want to call it. So getting down into the pelvis, trying to get away from all the bone and the intestines and try and find the bladder. And this guy's there's the prostate, and just trying to fan through that whole structure, trying to see if you can see any fluid sitting in the retrocovesicular space. All right, or pouch of Douglas for girls. Last part would be coming up and looking in the subcostal region. And just one quick look in a subcostal region, looking at ventricular size, function, whether there's a pericardial effusion. And I always add on at the top of that the fast scan. So I start on one side, second and third intercostal space, marker pointing towards the head, and try and look for lung sliding. Okay, and I don't think it's the pathology set up for lung sliding, but you get the idea. So I reduce the depth, and I have a look here for the difference between the soft tissue and the lung, and trying to see the ants marching sign, and do that on one side and do that on the other. Okay? So how about I change the pathology, and you tell me if you're seeing anything else. And I think it should be about that quick. We should try and keep out of the way of people. Obviously, wait till you've got a couple of minutes to do it. And I generally find it doesn't take longer than that. All right. Ravi, do you want to take you to the top of the screen? So we're just going to go for our right upper quadrant view, or looking in Morrison's pouch. Just going to try and fan through the whole thing. You can bag out my imaging if you like. What do you think?
So that's the, we can see liver, kidney,
yeah.
and Morrison's pouch. There is anechoic region, so that resembles fluid. Also, there seems to be some fluid under the diaphragm.
If I can give you a better picture. And again, I don't know how it turns out up there, but that's all kind of grey and quite close together sitting down there. So there's no echo-free space that we can see there. So is that what you were saying?
Yes.
Cool. All right, let's have a look over on this side.
On the left side, again, we can see the spleen and the kidney, and bit of echo-free space between the spleen and kidney.
Beautiful. So that's a small amount of fluid. That might be like 100, again, 200 mils sitting there in the splenorenal area. That would be a positive fast scan. Get into a CT scanner if you can. If you can't, go elsewhere. All right, nice one.
So we did not get a full view of the splenic capsule there.
Yeah, okay, you're bagging up my pictures. That's all right, I'll take it. I'll load you back.
Was there meant to be also? Sorry, was there meant to be also some pleural fluid on the right side? I thought there was the lack of the mirror image that you beautifully showed in the first.
Let me see if I can show it to you a bit better. Okay, so I'm just trying to come down at the side. So I'm there, I'm imaging through probably the 8th, 9th intercostal space there. So spleen sitting up there. And I'm just trying to fan through one all the way to the top so I can't see the splenorenal area. I'm trying to fan all the way through till I get to the bottom, almost all the way through. It's going to move up just a tiny bit and almost getting all the way through. And there's the echo-free space. And you're wondering whether there was a bit of fluid because we don't have the, Arnie, you're just saying because we don't have the lung artifact there.
I think it was more on the right side that I thought it, I mean, that was a little bit harder to tell, but. Oh, there it is. There it is. Okay, beautiful. Okay,
cool. And then the last bit, I hadn't completely finished it off, but sitting down here, looking into the bladder. There's a small bladder, and I don't think we can see any echo-free space on that side. All right, we'll try the next one. No prizes for guessing what this one's going to be. All right. Ben, do you want to take this one?
Yeah, everything's below the diaphragm though, so I have little interest.
You got to do it for the DDU. All right. Okay, so again, we've got the abdominal presets. We've got the marker on the left side of the image. So that means I've got my marker pointing towards the patient's head. I'm at 45 degrees trying to get through those ribs using that. Liver as my acoustic window. If I can try not to balls up the image. There we go. So I've got the liver here. Diaphragm's the bright white bit. We just sort of see the lung above the diaphragm up there. As I fan through the structure, here's Morrison's pouch with the right kidney, and we're looking in between here.
Yeah, on my resolution at least, it looks, I can't see any significant areas that are anechoic, suggesting fluid.
Okay, so I'm going to come over to the other side. Come down. Here I've got my spleen. There's the diaphragm. Here's the left kidney. And again, I'm going from one side all the way through to the other. Again,
there's no anechoic regions sort of between the organs suggestive of pre-abdominal fluid.
Very nice. Last but not least, I go down. You can have your marker either side. It doesn't really matter.
Yeah.
Dipping down into the bladder. Just ask you to notice the angle that I've got my probe. I think when I first started doing this, I was always imaging there and wondering why I couldn't see the bladder. You got to dip down into the bucket of the pelvis.
Yeah. Again, prostate, presumable bladder, and again, I mean, there's a small amount of anechoic space, quite inferior, but whether that's just a reflection because the prostate.
Yeah, that's really nice.
That's all I can see.
Yeah, that's nice. So it's actually this black anechoic area you're picking up, and these are quite subtle findings, I think, but I think that's quite good for teaching, to try and see the trying to see what a subtle finding might be. In my experience, when I've seen positive fast scans in trauma patients, it's not been subtle. You picked it up straight away, and people have been horrifically unstable, to be honest. But this guy's a good example to show it. All right.
Sam, can you show us in longitudinal section?
Very nice, very nice. Thank you very much for the great call. I'll then point the marker towards the patient's head, so the left is towards the patient's head, and I'll try and get you a better image because I'm not doing a great job at the moment. Tell you what I might do just for this, and you can't do this in your patients. Might just take off that. So bladder, prostate, and there's this echo-free space.
Yeah.
And Danielle, you're working in Liverpool, you've got an enormous amount of trauma, so please chime in. That's a great call to go both transverse as well as longitudinal.
Yeah, I don't do a lot of fast scans myself because I'm not often down in the ED for the trauma call. Sure. So our surgical team usually does that part of the role, but I do find, yeah, longitudinal section, because if you've got, you can see the bladder, right? And so, because usually when the trauma patient comes in, they won't have been catheterized yet at the time that you're doing the fast. So that's helpful actually, because then you've got your bladder as one anechoic space, and everything in the bladder, that's normal, that's fine. But anything at all outside the bladder, that's abnormal. So the longitudinal I find quite easy, because then you've got the lining of the bladder, and then anything underneath that, that's free fluid.
Awesome, thank you. All right. So that's fast scan. I think if you've got this far, and particularly with this audience, we should be going to EFAST scan, the extended fast scan, and that should include the heart. So again, we've got our unstable young patient come in, about a restrained trauma at high speed. So he's had a rapid deceleration injury, and he comes in immediately hypotensive with lots of superficial injuries on, a bit of a head injury. Danielle, just talk me through exactly what you're thinking with a guy who's unstable, recently after trauma, who has had a rapid deceleration injury. What are the potential diagnoses? Or what do you want to give broad brushstrokes about what you're thinking about?
Yeah, okay, so you're talking restrained motor vehicle, yes?
Yeah.
So you're thinking about things related to the seat belt, so shoulder, chest, and then abdominal injury as well. So you'd be looking for sternal fractures, retrosternal hematoma, aortic dissection. So any of those things might result in a pericardial effusion, which might actually be the finding that you find on the echo. Obviously, they're going to be high risk for chest trauma, but then also you'd be worried about mesenteric injury. So definitely looking for intra-abdominal free fluid as well.
Fantastic. So let's have a look at this guy. So again, we're just going to go through the same. I'll probably stop doing fast scans in a minute, but we'll just carry on doing it for the time being. So first of all, here's our first view. So looking through Morrison's pouch.
Yeah, that looks okay.
Cool. Left side splenorenal.
I think that's okay.
Okay.
In a real patient, I find the organs are really close together. Hey, on the model, there's a tiny bit of separation between them.
Great call. Absolutely, I agree. Okay, a little bit more depth.
All right, yep, bladder, yeah, that looks okay.
Beautiful. There's it in transverse, and I'll give it to you in longitudinal.
Yep.
They'll come up. I'll give you your parts.
Yeah, so I think there is a pericardial effusion there. It's small though. Is that right? Because I think I can see an anechoic space, particularly adjacent to the RV. It's more evident
nice. I might
in
just
systole.
see if I've... Yeah, but try. Sorry, maybe the pathology doesn't want to just don't want to point in the right direction. Imagine there's you can't see that sort of small pericardial effusion, because you could say it's maybe physiological because it disappears during diastole.
Yeah.
But absolutely hear what you're saying. So potential maybe for pericardial effusion. What about anything else?
Not sure.
Okay. I'm also going to go and have a look then. We're going to have a look at the IVC. I'm sorry, I'm doing it the wrong way around. I've got to do it back to front because I'm in a...
So
there's it in there's it in long axis.
yeah.
And this is the other thing that I quite like doing is I like viewing the subcostal view in short axis as well.
Okay. I think is what you're trying to get at that the LV cavity is obliterating during systole.
Yeah, really
and
nice.
That the IVC is very small and almost completely collapsed.
Yeah. So I think this takes a bit of a degree of thought because you could just rush past this view. I think this is one of the dangers, I guess, with echoes. You can get useful information. I guess if you do have a small collapsed IVC, here we've got a underfilled left ventricle, because the kissing ventricle sign. It's important that you've got to fan through the structure, make sure you're not just off axis off to one side. And then if I can, I'm going to do short axis view as well in the same area. So I've just moved the probe 90 degrees. So I've gone from there, just moved around 90 degrees and looked over to the patient's left. And we've got obliteration of the end systolic cavity. And it might look like he's got hypertrophy, but that's the pseudo hypertrophy that we get from an underfilled ventricle that makes the hypertrophy look a little bit worse. So what do you think with that? Because we had a negative fast scan, but we've got a hyperdynamic left ventricle.
Yeah, you have to integrate it with the clinical context.
Yeah.
If you've got a patient with a heart that looks like that, who's hemodynamically unstable, then you think that hypovolemia is the cause for the hemodynamic instability. Now, that may be that there's an occult bleeding source somewhere else, so in the long bones, for example, but there could be other reasons for the patient to be hypovolemic as well. Obviously, if it's a car crash trauma, then it's probably going to be bleeding, but trauma patients might be hypovolemic for some other reason, like they're intoxicated or they've had a long lie or something like that. So you need to keep an open mind and integrate with the clinical findings.
Perfect.
Maybe one other little comment there. I mean, in trauma, a pericardial effusion would commonly be small, and it only, because it's so acute, it only takes a small effusion to cause tamponade effect.
Yeah, great argument. Yeah. And so if it was small and you were looking into it, and I've had a couple of, what else can you do to go and have a look to see that that tamponade is the cause of what's going on? So just talk me through it, because I agree, small amounts of fluid can cause big problems. The two that immediately spring to my mind, we got people who came back from just being dead. You know, their pulse is GCS3 on 40 of double strength adrenaline or something ridiculous. And we took out literally 15 mils of blood and they came back ridiculously high. So it's a real phenomena. But what else do you have to go and do? Because sometimes it can be a bit hard to piece it together.
I mean, first of all, you will want to have a high index of suspicion, particularly if it's like penetrating trauma. If it's blunt trauma, you maybe want to be a little bit more cautious. I mean, you look at their neck veins and all those things, but again, that was a hypovolemic state that can fool you. So, but maybe volume resuscitation would always be a good step and see how they respond to it. And if they don't improve, then you know what to do. I mean,
and I have the big IVC as well. And also maybe if it's traumatic, we can sometimes see blood in the, you know, the hemopericardium can also be a bit of a clue if there's, looks like blood clots sitting in the pericardium. Nice. Okay, so again, hypovolemic patients. We're going to do echo this time, so I'm just going to move the markers around. If I can really do that. So I put them back to the normal way with the marker on the left side of the image. Okay. So I can't remember which one this is actually. Okay, let's focus on the heart a little bit. Where are we up to? Arnie, you happy to have a look at this one? So again, let's have the same thing. Let's have myocardial, so let's have, high-speed injury, hypotensive patient that comes in with a rapid deceleration injury. Danielle's been through the list of things that we worry about, right from chest trauma, the retrosternal injuries, abdominal bleeding. We talked about occult bleeding loss from long bones, from everything else. We need to integrate it into the clinical setting. So if you can see these, let's go through the same thing. Imagine he's a bit more tachycardic. I can't remember how to increase up the heart rate. Just let me have a look if I can. There we go. Perfect. He is now tachycardic.
Okay, so you're showing me a parasternal long axis view, and there may be a small effusion around it, but the RV doesn't seem to be collapsing.
Yeah, cool.
Looks like, yeah.
You're doing a great job.
So that's going for a short axis view there. So other things that I would be concerned in trauma would be cardiac contusions, mitral valve injuries, the thoracuspid valve injuries that sort of sit anteriorly.
Very nice.
I wonder whether it shows that the left ventricular function here is reduced. It should look more hyperdynamic in a trauma patient.
That's nice. All right, I'll give you the full chamber.
So there's some right atrial collapse there, which can be an unspecific sign unless it's more than a third of the cardiac cycle, which is very difficult for me to determine with the frame rate here.
Sure.
The RV, however, I do not see collapsing. I wonder whether it's now so fast that it doesn't come through.
Yeah, fair
properly.
enough. Let me see if I can slow it down a bit. Sorry. Start slowing that down. Excuse me.
The descending aorta looks okay there. However, the aortic disruptions are usually at the level of the ligamentum arteriosum, so they're a bit higher up. So it could easily miss that on a transthoracic image.
Fantastic. Just talk to me about the right atrial free wall collapse in a patient who's a young patient with restrained injury. I think this could be, as you were saying, just indicative of a potential, right atrial free wall collapse is a bit of an unusual finding in a young person. It just made me think about potential for tamponade, which is what this pathology was meant to be.
Yeah. Okay. It's certainly a potential, but probably also more likely if he was hypovolemic.
Yeah, beautiful. With the right atrial free wall, as well as the tamponade. Oh, sorry, Karen.
A young person who's otherwise healthy shouldn't have any pericardial fluid at all, should they?
Very nice.
Right atrial wall collapse then is a very abnormal sign in the absence of, a major motor vehicle accident. So if they're hemodynamically unstable, I think you'd be brave to say that tamponade is not contributing. But I agree with what Arnie said earlier, that obviously you would start with some volume resuscitation and see how they respond.
This is slightly unusual in terms of the pathology, because I've never actually seen the pathology this is actually meant to be. And one of the things that they're saying in the pathology for Bob is they're asking to consider lung injuries that we've got going on with this. And I've got to be honest, it's not something that I would immediately jump to mind when I'll be seeing this pathology, but I think it's worth mentioning that when they add in the lungs for this, I think it's just the one where they start talking about worrying about pneumothoraces. So here we can see lung that's maybe. This is meant to be the soft tissue. I'm sitting here, excuse me, if I should show you where the hell I am, first of all. So if I look on the right side of this patient, you get pleura sliding against each other, and this is meant to indicate for the ants marching sign. Yeah, it's not awful, but it's not the best, but you get the idea. So that's meant to indicate some normal pleural sliding sign. And then on this side, it's just the idea that you've got something completely different, potentially dealing with some form of pneumothorax on the left side, leading to some kind of right atrial free wall collapse is what the actual pathology is meant to be getting at. And again, I took the pathology off to try and make it easier, but you get the idea that they're suggesting that having some kind of pneumothorax associated with this pathology might be present. But I thought it was great to show the tamponade as well as
just on that
pathology.
I was looking to say, just on that view, it looks like the density of the lungs is different. Where that's meant to represent collapsed lung down or a component of intraparenchymal hemorrhage. The lung tissue there density is very different.
Very nice, very nice. All right, we'll keep moving. Oh. Yeah, I think. Yeah, absolutely. That is not normal. Do everyone see what Atim's talking about? Worried about this free wall collapse in there, or their free wall damage. We're going to come into this. I don't know what that is. It's certainly not the pathology that's written in there about having a free wall injury. I'm going to come onto the RV now. I think they've lost a pixel, yeah. But if we do get any kind of injury like that, I think it's going to look more like this one that we're going to go on to now, rather than one that's got a completely normal looking contraction of free wall without an RV dilation. And we'll come on to that right now. We just got a comment from the crowd. Mode from Pericardial Effusion. That was just a comment from the group saying that if we are worried about how long it's going to be collapsed for during the cardiac cycle, using M mode might help, and I think that's a reasonable comment. All right, a couple more, and then we will go through other exam questions. Lewis, were you keen on having a go at one of these? Lewis McLean?
Sorry, yeah.
Do you want to have a quick go? All right, so further to the conversation, I kind of gave it away. So this again, restrained passenger, high-speed motor vehicle accident, so the deceleration, and we're concerned about causes of hypotension. So we'll just give you a view. I think that's kind of the best I'm going to be able to give you. Just plan through it so you get an idea.
Yep. Yeah, look, it's a little bit hard to tell, but it does look like the RV's a bit bigger than the LV in the pictures that I'm seeing, but the LV's a bit off axis, so
yeah, absolutely,
probably not able to be accurately commented on. And there's also
some young patient who's just had a motor vehicle accident. What would you be thinking? And what's the treatment and management, I guess?
So I'm not certain that I've accurately identified the pathology. There's also some sort of interference coming down from the top of the sector, which I'm not certain where that represents pneumothorax or.
No, I imagine it's just an ordinary lung artifact. So we're just going to focus on the heart for this one. So you said you thought the RV was bigger than the LV, so it's going to be at least moderately dilated. RV function.
So it looks like it's down. and you'd be thinking that there might be blunt myocardial contusion, but you'd also want to check the valves. And as Ani said, the anterior valves tend to be the ones that are ruptured.
Beautiful.
Primarily.
So we can go and have a look. And although the pathology is not complete with this, I guess the other things I'll be looking, if you do have this dilated right ventricle with some impairment, you know, the right ventricle could be called the anterior ventricle, because it's obviously, and that's the one that can often be injured by blunt trauma. So also having a look for some of the anterior free wall being thickened, so that RV free wall being thickened, or the pericardium being thickened. I think this is where we might see some of those septal defects perhaps was talking about. If we've got effusions that are going along with this, you know, concern for right ventricle injury. And yes, I think that's probably about it. What do we worry about with these things? So down the track, I think if it looked like this, tell me how it would impact your management of this patient.
Well, so the management is supportive with a high index of suspicion for the patient deteriorating and also having other associated injuries. So, I mean, TT imaging like this with a suspicion of blunt myocardial contusion that was significant enough, and no other surface imaging, I'd probably think about performing a TOE early after the patient was stabilized and had a CT and multi-system injury was managed. And hopefully the TOE might shed a little bit more information. The things that people can die from very quickly are obviously the free wall rupture and catastrophic valve failure, as well as aortic dissection.
Nice. He's on your unit, and you are called to see him urgently 2 days later after he was intubated and he had a small pneumothorax. You've sorted that out. You're looking towards extubation 2 days later. You know, his leg was broken or something, and this is what you're called urgently to see him in the middle of the night, and this is what you find.
So it doesn't look like there's any pericardial effusion there. A little bit hard to tell. Once again, the RV looks big. The function looks impaired. I think that's a moderator band that I can see on the simulator.
Yeah, so again, we've got a two-dimensional imaging tool, three-dimensional structure, and so we've got to be able to look through the whole thing.
And some colour on the valve.
Give you the colour on the valve. So no major tricuspid regurg. And the valve looks like it's functioning normally.
Yeah. So this, so I think prior to this, we would have established the diagnosis of blunt cardiac injury due to contusion, and we would have been following serial troponins and echocardiography as well.
And his would certainly been through the roof.
Yeah, so it looks like it's worsening RV function, and so RV support would be what would be appropriate, depending on how the chest X-ray looked. Whether there was pulmonary contusion as well might be how you might determine how you would approach the RV support.
And I'm just going to show the other. I don't know how well this projects. Is this color Doppler through the septum? So as well as the RV getting hit, it can also be the septum, and worrying about, as well as the free wall rupture, worrying about ventricular VSDs from areas of ischemia as well, from areas of necrosis. Pretty rare, I've never seen it, but just to worry about the delayed presentation after cardiac injury of septal defects. I think more commonly areas of akinesis or aneurysmal areas, but I guess you can get horrible VSDs like this. Just a rare one.
Yeah, sorry, that's not showing up very well on my iPhone, but
Can I just Can I just mention something else, Sam, before we go on? Just apart from direct myocardial damage, if you've got a patient with long bone fractures and RV dysfunction, you would also need to consider embolic phenomenon. So, you know, PE down the track, or also fat embolism, for example.
That's just exactly what Louise was just saying here. Yeah, very nice, very nice. Yeah. So prior injury, the comment there was, don't forget about prior injury before this, in terms of people who are having the car accident because of an MI or something like that. Sure. Just in the meantime, I'll just remember the last one to do. I think it was mentioned at the beginning by Arnie, was talking about not missing pathologies with tamponade. And although this guy won't have a tamponade, I don't think, if I remember correctly, although there's not a major tamponade here, if we do see a tamponade and there's a bit of blood in the pericardium, don't forget to go looking for the dissections. And even if we can't see those dissections in your standard views, if you've got a pericardial effusion you're worried for, don't forget to sort of tilt up and look, go off axis, looking for fanning through your aorta, looking for dissection flaps. I think traditionally, the teaching's been that if you're getting horrible dissection flaps from, you know, like ruptured aortas, these guys probably don't make it into the ED. But if they do and you've got hypertension, you're not quite sure, don't forget to go off axis looking for dissection flaps, and even coming up into the suprasternal views, shining down into the arch of the aorta. You can see it just down there. All right, guys. Well, that's about it, really. I think it's so I guess it's a fairly common question that's going to be asked in the exam about trauma, because it's you know, you've got so many issues that could potentially go on. I think broad, if they ask about it, don't forget to talk about FAST and EFAST and pneumothoraces, obviously all the normal ones. I think, as Lewis McLean was mentioning, that you've also got TOE at your disposal if you're worried, particularly about with aortic dissections, and then it's a really subtle cardiac pathology. And the final one to say would be using ultrasound to guide procedures. Everything from putting in lines to draining pericardial effusions. I think it could be used to help with diagnosis, help with guiding management, and help with procedural guidance as well. Okay. Well, that's it. And then any other comments? I think that's sort of everything I can think of regarding sort of the use of ultrasound in trauma. I don't think, are there any other ones that people can think of? Yeah.
I think I would just mention that the retroperitoneum is not imaged or well imaged by FAST, so it's possible to have a significant retroperitoneal hematoma that's not diagnosed, and you wouldn't pick it up. And so that would be an important caveat. Possible to see long bone fractures on ultrasound as well, of course, but it wouldn't be your first investigation of choice.
Yeah. All right. Well, thanks very much, guys. How about if those of you want to hang around and talk about some of the written answers after this, that'd be great. Otherwise, I'll say thank you very much for joining us, and I'll see you guys next week.